First of all, thank you for asking me to come along and speak today. So, my name's Leah and I work in for Somerset Partnership NHS Foundation Trust. And I'm here to talk about the process that we've been doing in Somerset of preparing an application to submit to the local clinical commissioning group for an improved service for adults with celiac disease. And it's specifically looking at a service to provide a follow-up for patients 1 year after their initial diagnosis. So to start off with, just to give you a bit of background to the project. So I work within a primary care dietetic-led gastroenterology clinic, which was commissioned by the local CCG in 2012 to see patients with IBS and gastrointestinal allergies. And one of the key factors that led to the successful commissioning of this clinic was that secondary care had identified significant cost savings that could be made by incorporating that clinic into a IBS management pathway, whereby GPs were asked to refer patients with IBS and no red flag symptoms to that clinic for dietary advice before considering sending them to gastroenterology, which in the past had led to expensive but often unnecessary investigations. So once that clinic was set up, it was always felt that the management of celiac disease could quite easily be incorporated into that setting. And one of the reasons for that was because as a dietitian working in that clinic, as the symptoms of those conditions are so similar, we were always on the lookout for the potential misdiagnosis of celiac disease. So from that, there was already a working group set up called the Flexible Healthcare Gastroenterology Group, who developed the initial bid for that dietetic-led clinic. And their remit was to develop elective pathways in gastroenterology for Somerset clinicians. And once the clinic was up and running, seeing patients with IBS and gastrointestinal allergies, there was an agreement among the members to start reviewing the service offered to patients with celiac disease. So in terms of who was on that working group, we had the secondary care gastroenterology consultants who were keen to move the management of their medically stable celiac disease patients from secondary care into primary care to free up their time for the more complex patients and newly diagnosed. We had myself and my colleague who work within that dietetic-led clinic, the head of our community dietetic service, a pathway development manager from the local CCG, as well as a local GP who was also a member of the CCG's clinical operations group. And it was that clinical operations group which advises the CCG on what clinical services to fund. And in order to submit an application to them, we actually needed the backing of at least one of their members. So it was really important to have that member working alongside us. So that's kind of the background to why we decided to look into celiac disease and who was involved. So what I'll do now is just take you through what we've been doing in terms of preparing our application. So first off, in terms of identifying the need for an improved service, we always believe that patients in Somerset with celiac disease weren't getting the follow-up care they should do, but we kind of needed to prove that. So to start off with, we tried to find out how many patients in Somerset had a diagnosis of celiac disease. So from the local GP's coding systems, we found that 1,261 patients had a code for a diagnosis of celiac disease. Just as a comparison, we also contacted Coeliac UK to find out how many of their members had Somerset postcodes. And they reported around 1,300 patients had Somerset postcode. Obviously, not everyone who joins Coeliac UK has a confirmed diagnosis, but equally, as Joe showed before, not everyone with a diagnosis of celiac disease joins Coeliac UK. But in terms of the numbers we would be expecting, so if we were to go on national reports which estimate 1% of the population would have celiac disease, we would expect to see around 5,300 patients in Somerset with celiac disease, therefore identifying a need to try and increase the awareness of the condition and the diagnostic rates. So we had over 1,200 patients in Somerset having celiac disease who should, as per national guidelines, be receiving annual reviews as recommended by the BSG and the PSSG. So what was actually happening in Somerset? So they were remaining in secondary care following their diagnosis and up to 3 to 6 months, and they were seen by gastroenterologists along with a specialist dietitian in secondary care. And in terms of what was happening at annual review, we did a scope exercise and found that in the previous year, secondary care had reviewed around 500 patients with celiac disease, either by a specialist dietitian or a gastroenterologist. 60 patients were reviewed at the GP surgeries via their in-house community dietitian. And then, so it's possible that over 700 patients in Somerset with celiac disease had not had an annual review, therefore helping to provide us with some support for our proposal. So in terms of the solutions that we were going to try and come up with, we contacted Coeliac UK to find out what was going on countrywide, also spoke with other local departments to find out what they were doing. So we looked into the concept of things such as group sessions, the remote clinics which were happening in Southampton and in Bournemouth, pharmacy-led schemes, one-to-one appointments with dietitians, and the joint clinics with nurse specialists and dietitians. So if we were going to put a proposal to the CCG, we wanted to make it as cost efficient as possible and ideally long-term sustainable. So in terms of developing our service proposal, we decided to go down the route of the virtual annual clinics, and the pathway that we were proposing was that patients would remain in secondary care up to their first annual review. At that point, if the secondary care team felt the patients were medically stable, they could be transferred to the care of primary care and assessed via the virtual annual clinics, which would involve a completion of a questionnaire which assessed symptoms, adherence to the diet, along with some blood tests which would be done at the local GP surgeries. That information would then be reviewed by the specialist dietitian, and if required, followed up with a telephone review, which they may provide some advice, or onto a one-to-one appointment with the dietitian. The patients would also have the option of seeing a dietitian if they wanted to. But if there was any concerns at any point, the patient could be referred back to the general practice and back into the secondary care if needed. If not, they would continue within that virtual annual clinic process. Running alongside that, we also were going to invite patients to annual update events, which would include holding talks covering various topical areas. So that was the pathway that we were proposing, and we wanted to try and find out if there was any evidence around to actually support that proposal. So we actually contacted Coeliac UK to see if they could guide us with this, and they very kindly did a little bit of work for us and provided us with a document which provided some of the evidence to support the importance of following up patients with celiac disease, as well as those that identified the consequences of untreated celiac disease and poor compliance to the treatment. There was also the references available to show that patients actually preferred to have access to a dietitian for follow-up. And in terms of the use of the virtual annual clinic, that was based on the information gathered by the team in Southampton who were already running that virtual annual clinic approach. So we got to the point where we had developed a potential proposal and we had found some evidence base to support that. But now it was actually important to involve the potential service users to assess what their opinions were of living locally with celiac disease, but also learn about their experience of the previous service and what their thoughts were on the newly proposed services. So the Somerset Clinical Commissioning Group actually led a patient consultation in the autumn, and they developed a questionnaire with input from ourselves and Coeliac UK, and that was distributed to the GP surgeries and sent out to all those patients who had a registered diagnosis of celiac disease. Coeliac UK also sent it to their members who had Somerset postcodes. So we were aware that some patients may have got 2 copies, but we wanted to make sure we reached as many people as possible. And there was also the option of completing it online via the CCG website. So in terms of the questions asked, we wanted to find out about their experience of diagnosis. So ask questions regarding the time to diagnosis and symptoms prior. We wanted to know what their experiences was of having annual contact with health professionals, as well as access to annual blood tests, whether they utilised any other additional support options available, such as membership with Coeliac UK and the use of prescribable gluten-free products, and then also, importantly, to find out what their preferred method of follow-up would actually be. So just to share some of the results with you, which we feel help support our proposal, we had 359 patients respond to it, with the majority of those being over the age of 60 and 71% of them being female. In terms of the question, have you seen a healthcare professional in the last year regarding your celiac disease? 58% said they had, but still a large proportion said they hadn't seen anyone in the previous year. In terms of access to annual blood tests, again, 41% said they hadn't had an annual blood test in the previous year, thereby, again, providing some support for the need to improve that area. Now, the important question of what form of annual review would prefer. So we gave them various options such as completion of questionnaires, appointments in a hospital, in a community-based hospital, and the most popular option was an outpatient appointment in a community hospital. But if we were to take all those options which were included as part of our service proposal, which was things such as a telephone review, completion of questionnaires, and the option of having a one-to-one appointment with a specialist dietitian in a primary care setting, that would equate to about 59% of respondents opting for those options. And in terms of the question, who would you prefer to complete your annual review? The most popular was a specialist coeliac dietitian based in the community, with the second most popular, a gastroenterology consultant based in the hospital. But altogether, if we were to look at it, 50% of them patient respondents would prefer to see a dietitian, with the majority preferring them to see them in the community. We also asked them if we were to provide some other additional support, what would their preferred options be? So 56% said they would like to see improved training of health professionals, including GPs, which we would hope would increase the awareness of the condition as well as improve the diagnostic rates. 22% said their first preferred option would be a leaflet to provide up-to-date information on gluten-free foods available on prescription. 10% said they would like to see local support groups run by volunteers, and another 10% said they would like to see the provision of supporting information. So in terms of what comes next, so we've gone through the process of identifying the need to improve the service and what solutions we've come up with, as well as gather some support for that proposal. So at the moment, we are currently finalising the business case, and our local CCG asked us to submit 3 options, from one that costs the least to the one that costs the most. So the options that we've put forward are the delivery of annual group events, as well as training for health professionals. Option 2 was the group update events and the training, along with annual assessments of patients with celiac disease via the virtual annual clinic. And the final option would be same as option 1, but with annual assessments delivered via a one-to-one appointment with a specialist dietitian in that dietetic-led gastroenterology clinic. So in the coming months, that business case is going to be finalised, and the aim is to present it to the clinical operations group in April-May time, and then it's just a matter of awaiting their decision. And just to finish off, someone asked me what I thought the key factors were that supported our case. I think the first thing is that we had a working group with the appropriate mix of members. So we had representatives from both primary care and secondary care working together to come up with that proposal. Secondly, the patient consultation. So I feel that patient consultation was really important to our proposal to ensure that the potential service users had a voice in that decision-making process. And once a clinical commissioning group set out to do a patient consultation, there's more of an obligation to actually respond to that. And finally, the fact that we already had an established cost-effective primary care dietetic-led gastroenterology clinic set up, which already had the skill mix there to review and offer a follow-up service to patients with celiac disease. So that management could easily be incorporated into that. So thank you for listening, and if you want a copy of the consultation and the results which got published last week, you can get that from the Somerset CCG website.
Questions from the floor? Leah, may I ask you a question?
Yes.
What do you think the outcome will be? You're at consultation?
I have absolutely no idea. We have been told that there may not be any new funding available, so it's a question of whether we can find some funding taken from elsewhere. Our clinical commission group is speaking with our medicines management team to see if we can link it in with a pharmacy-led scheme, whereby we hopefully might free up GP time of patients going to see a GP to change the prescription, and that could be done via us and a pharmacy. So we don't really know, to be honest, but we are hopeful.
Please introduce yourself.
Hi, thanks very much for your talk. I'm Peter Gillett. I'm a paediatric gastroenterologist from Edinburgh. I think these 2 talks are incredibly helpful for all of us, because I think we're all struggling with how we actually see patients and offer the appropriate advice. Based on the number of patients, you're saying around 1,200.
Yeah.
what's the kind of whole-time equivalent staffing that you've put into your proposal for those patients?
So for the virtual annual clinic, we've put in one working time equivalent band 6 specialist dietitian along with a bit of admin time. But alongside that, there was an agreement that secondary care would give some clinical supervision as well. But that wasn't funded.
So overall for the whole...
Yeah, so for the virtual annual clinics and the annual update events, we're looking at a one-time working time equivalent.
I thought that was very interesting, Paul Secretarius and Thomas's London. I see a large number of tertiary referrals from the Brighton and Hove, Sussex area, where the GP consortia will not actually allow prescription of gluten-free foods, with the exception of one, that whatever's the cheapest gluten-free product at that time. And there's clearly increasing pressure to go that way. Is that your experience with your GP consortia group, or where do you feel this is going? Because it seems to me clearly Coeliac UK is very important in this, to have some sort of national basis. But having actually spent, dare I say, an hour with the Prime Minister in relation to this sort of thing, they're clearly looking to cut anything they possibly can. Yeah. And I just wonder how you feel this should be taken forward.
I mean, at the moment, Somerset are adhering to Coeliac UK guidelines, and the fact GPs will prescribe the set number of units. It's more to do with what they would prescribe, so they will only prescribe the basics. I think there was some scope in terms of trying to determine what actually goes on that prescription list to try and reduce the extra costs, which are sometimes found when gluten-free products come from outside a specific warehouse, etc. I think we could potentially, as I said, free up some of the GPs' times by combining sort of a virtual annual clinic approach with a pharmacy-led scheme. But at the moment, Somerset, as I said, are adhering to those guidelines at the moment. As far as I'm aware, there's no thoughts of trying to change that at the moment.
One thing that we've been discussing, Leah and I, because we work together.
So this is Marianne Williams, who I work in the dietetic-led gastroenterology clinic with.
Is the tying in of the availability of prescriptions with the dietetic-led clinics. In other words, they have to be signed off by the dietetic-led clinic before they're eligible for the prescriptions through the pharmacy-led scheme. So if we can somehow tie those two together, the idea being that if they are being reviewed, they're less likely to get complications, or you hope they may be more compliant and less likely to get complications. So you're reducing those long-term costs as well as tying it into the pharmacy-led scheme. So I think I can see the two working very well together. I don't know if anybody's got any experience of that happening anywhere else. Would like to know about it.
Final question.
Derek Jewell, Oxford. Thank you. Does the diagnosis of celiac disease in Somerset rely just on serology, or do you insist on a biopsy as well?
At the moment, biopsy as well. Yeah.
So that's all built into the... and if you see the patient in your dietetic-led clinic, and you find they've got a positive antibody, are you able to refer them for endoscopy, or does that have to go through the gastroenterologist?
So if a patient comes to us without a diagnosis of celiac disease but has a positive serology, we would then refer them straight back to secondary care before giving any dietary advice for that endoscopy.
Refer them back to primary care?
We are a primary care-led clinic. So when patients are referred into our clinic, which at the moment is commissioned for IBS and gastrointestinal allergy, patients have to have had a celiac screen before they're actually referred to us. So hopefully will bypass that happening. So they should have had a negative celiac screen before they're actually referred to into the clinic.
Thank you very much, Leah.
Thank you.